Hey guys, welcome back. I'm Akanksha Jain, your clinical psychology educator, and this video is brought to you by Cyclothymic. I hope you're all doing well today. Okay, so today we will be discussing mood disorders, starting where we left off. But before we start that, we'll have a quick revision of whatever we did in the last session. So, whatever we did in the last session was we covered neurodevelopmental disorders, we covered schizophrenia, spectrum disorders, and we also covered classification system. We started with why do we need a classification system? So basically, it is a common language for everyone among every mental health professional. Okay, there were two systems, DSM and ICD. DSM was Diagnostic and Statistical Manual of Mental Disorders. It was given by APA, and the recent one is 5TR. Okay, it consists of only mental health disorders. Then we also have ICD, International Classification of Diseases by WHO. The latest one is 11, and it contains all the disorders, everything, with mental health disorders as well. Then we looked into its evolution, especially changes from 4 to 5TR, like removal of multi-axial system, inclusion of autism spectrum disorder, the dimensional assessment, and including prolonged grief disorder. Then we moved on to neurodevelopmental disorders. We discussed IDD, ASD, ADHD, SLD, communication and motor disorders. Let's discuss intellectual disorder first. So what we said was there should be two deficits. What? Adaptive deficit and intellectual deficit. When should it be? The onset should be during the developmental period. And this deficit in the intellectual as well as adaptive functioning should be across a lot of settings and multiple activities. Okay. And according to 5, the division, the severity level is based on the adaptive levels rather than intellectual levels. So we said there is mild, moderate, severe, and profound. Okay. We also discussed this etiology based on prenatal, perinatal, and postnatal. Then we moved on to autism spectrum disorder, where we said that deficit should be in two areas, where social communication and interactions, and the second should be that there should be restricted or repetitive patterns of behavior, interests, and activities. Okay, it should be clinically significant. It should be present in multiple contexts, and again during developmental period. Then we moved on to ADHD, attention deficit hyperactivity disorder. Three main key features: inattention, hyperactivity, and impulsivity. Okay, where it should be in more than two settings. Okay, the impairment should be significant. And when should it be detected? Before 12 years. Remember that. Then we moved on to specific learning disorders, where we said it is not an intellectual disorder. There is no intellectual deficit. There is deficit in academic settings. Okay, we said that it should be for more than 6 months. Then we talked about its three types: dyslexia, dysgraphia, and dyscalculia. Okay, and then we discussed some of the major assessments for these. So for IDD, intellectual disorder, we said that for adaptive functioning, what do we use? VABS and ABA5. So VABS is VABS, VABS and ABA5. And then for intellectual functioning, we talked about WAIS, WAIS, MSc, MISIC, and DKT. Then for autism spectrum disorder, we talked about ISA, which is a gold standard in India. We talked about ADOS-2 and CARS. And then for ADHD, the gold standard is Conners rating scale. We also talked about some of the medications of ADHD, methylphenidate, which is a stimulant, and atomoxetine, which is a non-stimulant. Then we moved on to schizophrenia spectrum disorders, where we said that it is easier to define based on the durations mostly. So first we looked into the criteria, in which we said there are 5 features, out of which 2 should be present. Okay, which were they? Delusions, hallucinations, disorganized speech or thought, and disorganized behavior, and then negative symptoms. Out of which the first 3, delusions, hallucinations, and disorganized speech, at least 1 should be present. In total, 2 should be present, but among the first 3, at least 1 should be present. Then we talked about what are the negative symptoms as well. We talked about alogia, avolition, anhedonia, affective flattening, and asociality. The rest were delusions, hallucinations, disorganized speech, disorganized behavior were positive symptoms. We also talked about 3 phases of schizophrenia, which are prodromal, active, and residual. Okay. Then we talked about the different, as we said, it's spectrum, so different disorders. So brief psychotic disorder, when it is diagnosed, when these symptoms are for 1 day to 1 month. Schizophreniform, 1 month to 6 months. Schizophrenia, more than 6 months, in which at least more than 1 month should be the active phase. Then we moved on to schizoaffective disorders, in which we are saying there should be the schizophrenic symptoms, of course, but it should be accompanied with a major mood episode. It could be mania, hypomania, okay, or depressive, but which we will be studying today. Okay, and this major mood episode should be present for at least 2 weeks without the schizophrenic symptoms. Then we moved on to delusional disorders, in which we said that these delusions should be present for more than 1 month and it should be of non-bizarre nature. We talked about erotomanic, grandiose, jealousy, persecutory, and somatic delusions. Then we discussed why does schizophrenia develop. We discussed about the diathesis stress model. We also discussed some important assessments like PANS and BPS, and we also talked about antipsychotics. So this is what we discussed in the last session. Okay, now if you would like detailed notes which are concise, colorful, it has mnemonics and examples which could help you remember, everything very easily, you can find the link in the description below. Now we will also discuss, how you can attempt the mock test for the session later. Okay, so now let's talk about today's journey. We already said that today we will be discussing mood disorders. What will we be covering? So the 2 types of mood disorders, depressive mood disorders and bipolar disorders. And then we'll also be covering theories of depression, its etiology, its assessment, its treatment as usual. So now let's start with asking a question. The question is every sad person depressed? Depression is one of the most commonly used term in the layman language. Whenever someone is sad, someone is bored, someone is just unhappy, they'll say, I'm feeling depressed. Oh, you're depressing me. Is it correct? Is it okay to use these terms so casually? Suppose you failed an exam, or you had a fight with your friend, or, you had a fight with your parents, okay, and now you're feeling very low. You feel sad, you feel disappointed, maybe you can feel guilty even, you just want to cry, you want to be alone. Does that automatically mean that you have depression? No, right? So feeling sad is a normal human emotion, okay, a normal human experience. On the other hand, depression is a mental disorder, okay. So let's talk about these 2 pictures in front of you, okay. In the first picture, we can see the girl. She failed her exam. She felt bad for a while, but she can still enjoy other things and she can manage her daily activities. So let's move on to the second picture. Now she's saying that I haven't enjoyed anything for weeks. The sadness that she's feeling doesn't go away. She feels drained, hopeless, empty. And it is also affecting her in different domains like her studies, relationships, her daily life basically. So in the first question, she feels bad, but she gets better. So that feeling is for a very short time. While in the second, it is prolonged. So could it be depression? Maybe. But can we just diagnose? No, right? We don't just diagnose someone because they are sad, but we ask questions like how long, how severe, is it affecting their daily functioning, what are the symptoms? Based on these questions and based on these assessment, we can maybe come to some kind of diagnosis. Let's take this one step further. Before moving on to full-fledged mood disorders, let's understand first of all, what is mood? What does we mean by the term mood? Okay, and is it different from the term emotion? Okay, let's see. So, we are saying there are 2 terms, mood and emotion. Now, emotion is short-lived. Okay, short-lived. It is like a response to a specific event. Okay, suppose you saw a horror movie, you're scared, you got a good news, you feel happy, okay, or your mom scolded you, you feel sad. So these emotions are short-lived. It could be for minutes, it could be for hours, okay, but then these feelings start to settle down. On the other hand, mood is like, emotional climate of the person itself, emotional climate. Let's understand this by the term, okay, it's raining, okay, so it's a rainy day. Does that mean it is necessarily a rainy season? No, right? We have rains in summers as well, in winters as well. Okay, that does not mean it is the rainy season. Okay, we also have rains in the rainy season. So there's a difference between having a rainy day and a rainy season. Emotion is like a rainy day. Mood is like a rainy season. Okay, so mood is the emotional climate. So how do we decide that? Okay, how do we decide when this mood is becoming a disorder? It is based on 3 things. First is duration, second is severity, and third is functional impairment. Is this emotion, is this feeling very persistent? Is it affecting your daily functioning? Okay, is it causing you severe impairment? These are some of the features when we even think about it becoming a disorder. Okay, because no one can stay happy or no one can stay sad all the time. Okay, this is like a spectrum. Mood is a spectrum, you know. Sometimes we feel happy, sometimes we feel sad, sometimes we just feel not neutral. So this mood exists on a spectrum, and this is very very normal, very human experience. So now these mood disorders has two major groups. First is depressive disorders, and the second is bipolar disorders. Okay, so what comes under depressive disorders and what comes under bipolar disorders? Before moving into that, let's understand what do we mean by the term depressive and bipolar in very short. Okay, obviously we'll go into detail. So depressive basically means a low mood, okay, interest in nothing. Okay, so that is what we're discussing in depressive disorders. While when we talk about bipolar disorders, it is swings between the mood. Okay, low mood, high mood. So if we say that, you know, moods exist on a spectrum. So if this is the spectrum, okay, we are saying there is low mood and there is high mood. Okay, what do you mean by high mood? Okay, it could be abnormally elevated. Okay, it could be irritable, elated, extreme happiness, extreme you know, high functioning. So that is abnormally high and abnormally low as well. So when there is one of these, okay, when we are talking about low, we are saying it's unipolar, only one pole. Okay, unipolar. But when there is a swing between low and high, right, it's a swing between low and high, we call it bipolar. We call it bipolar. Okay, so this is how we decide that is it a unipolar disorder or bipolar disorder. Depressive disorders were also known as unipolar disorders. So what disorders come under depressive disorders? Major depressive disorder, persistent depressive disorder, also known as dysthymia. There is premenstrual dysphoric disorder, disruptive mood dysregulation disorder, and substance/medication induced depressive disorder. It is basically that there is some kind of medicine that is responsible for this mood, or some kind of substance use that is responsible for this mood when we talk about substance/medication induced depressive disorder. In bipolar disorders, we have bipolar 1, bipolar 2, cyclothymic. Same thing here also, substance/medication induced bipolar related disorder. Okay, and then bipolar and related disorder due to another medical condition. So there could be another medical condition which is causing this disorder, and then the first one we are saying there is a medication whose symptom is these bipolar symptoms or the substance use. Okay, so now let's move on to the first depressive disorder, which is major depressive disorder, MDD. Now, when we talk about the clinical diagnosis of MDD, we understood the depressive disorder, we are talking about low mood, no pleasure and everything. How do we clinically diagnose that? So for clinical diagnosis, we have three main things that we need to look into. The first is there are 9 symptoms in DSM-5. The 9 symptoms, we should have at least 5 out of these 9 symptoms. 5 out of these 9 symptoms. How long should these persist? You know, we discussed duration, severity, impairment, right? So this is the duration part of it. At least 2 weeks. For these 2 weeks, these symptoms should exist almost every day, every time. Okay, for at least 2 weeks. Okay, and it should cause some kind of distress or some kind of impairment in their social functioning, in their occupational functioning, in their daily functioning. It shouldn't be like, okay, I feel sad and it has been more than 2 weeks that I'm feeling sad, but it is not causing any kind of distress to the person, any kind of impairment to the person. It shouldn't be like that. So now that we know what the clinical diagnosis is, let's look into what these 9 symptoms actually are. Okay. So as we already said, we need at least 5 symptoms out of these 9 symptoms for at least 2 weeks. What are these 9 symptoms? Now, before moving on to these 9 symptoms, do we need all these 9 symptoms? We already said no. We need only 5. Any 5 would work? No. From these two, at least one should exist. Which two? Depressed mood and loss of pleasure or interest, loss of pleasure or interest. So what we are saying basically when we are saying depressed mood, it is feelings of hopelessness. That is what we call depressed mood. In children, it could be more in terms of irritation. They are very irritated. It's not more of depressed, but it's more on the terms of irritation. Okay, what do you mean by loss of interest or pleasure? I don't feel like doing anything anymore. That is what we call loss of interest, loss of pleasure in things that you used to enjoy before. So at least one of these should be present. Now, let's look into the rest of the symptoms. The third, we are saying that there should be any kind of weight loss or gain. It could be more, it could be less. Or you feel more hungry than normal, or you feel less hungry than normal. Any one would work. Then the fourth says that either you want to sleep a lot, like more than what you normally sleep, especially, you know, more than 7, 8, 9 hours that we call. It's like you're sleeping for 15 hours, 18 hours, something like that. Or you cannot sleep. You cannot get proper sleep. Okay, like you're sleeping for just 1 hour, just 2 hours, and you feel so tired. Then moving on to psychomotor agitation or retardation. What do you mean by these terms? So when we talk about psychomotor retardation, we are saying that it's more, you know, every function that you're doing, even when you're moving, it's very slow. This is one of the features that is observable by others. The others are something that people cannot observe outright, but this is something that can be observed. And when could be psychomotor agitation, you're fidgety, you cannot just sit still, you know, you're always pacing around, things like that. Then we have fatigue or loss of energy. You know, you're always feeling tired, you're always exhausted, the feeling of that. Then feelings of worthlessness or guilt. This is over the top feeling of worthlessness, hopelessness, guilt. Basically having the negative beliefs about oneself to the point that it is over exaggerated, it is so excessive and over the line. Then diminished ability to think or concentrate. They're not able to concentrate anywhere. They're not able to focus. Normal decisions take so much effort, so much, you know, mental energy that they're not able to make very simple decisions. Like, you know, what do I want to eat today? Even that particular thought could be very distressing to them. And the ninth one, very, very important, should never be skipped, is recurrent thoughts of death or suicide. It includes, you know, thinking about being dead, willing to be dead, suicidal thoughts, any attempts, any plans, okay, anything related, even suicidal ideation, self-harm. We talk about all of this here. Okay, how can we remember this? Through this word, SIGCAPS. Remember this, it will make it easier for you to remember it. Okay, so now that we discussed these 9 symptoms, we discussed the duration, we discussed that it should be distressing or cause some kind of impairment. Let's try and apply it. Okay, so this person came to you. Her name is Sunita. She's a 42-year-old school teacher. Okay, now she reports that for the past 6 weeks, I have felt completely empty. I wake up at 3 a.m. and cannot sleep. I have lost 4 kgs without trying. I sit in staff meetings unable to concentrate, and I have cancelled all my social plans. Nothing feels worth it anymore. I have even thought I would be better off not existing. Now, let's try to apply the DSM criteria. First thing first, okay, we said it should be at least 2 weeks, all day, almost every day, right? She's reporting this for past 6 weeks. Okay, so do we fulfill the timeline, the duration criteria? We do. Then let's move on to symptoms criteria. So we said that either depressed mood or loss of interest or pleasure should be present, right? She feels completely empty. Can we say that it is a sign of depressed mood, right? She has cancelled all her social plans. Can we also say that that is loss of interest, loss of pleasure? Okay. Then she wakes up at 3 a.m. and cannot sleep. Insomnia, loss of sleep, not hypersomnia, insomnia. Okay. Then she has also lost 4 kgs, weight loss. We also have weight loss. She sits in staff meetings unable to concentrate. Okay. Can we say poor concentration here? Right? And this also shows impairment in occupational settings. Okay. And also social settings. She has also cancelled her social plans. Nothing feels worth it anymore. Feelings of worthlessness. Right? And I have thought I would be better off not existing. Can we say this is a suicidal ideation? Yes, we can. So, now we said at least 5 symptoms should be present, out of which 1 should be at least depressed mood or loss of interest. Okay, and then 1, 2, 3, 4, 5, 6, 7, 8. Out of 9, we have 8 symptoms here. Loss of energy also we can say, right? She's not able to concentrate, she has cancelled her social plans, she feels completely empty. Hai So she does fulfill the DSM criteria for major depressive disorder. Okay, how many symptoms are present? We just looked into it. Okay, so now let's move on to the fact that MDD, major depressive disorder, also has some specifiers. What do we mean by the term specifiers? Specifier basically means how does the disorder present itself. Okay, it's not a different disorder in itself. It does not change the diagnosis. It just adds on to the diagnosis. Okay, so let's discuss some important specifiers only. The first is melancholic. This is a classic case, classic depressive specifier in which you have very classic depressive symptoms, and mostly the cause is biological. Her feelings, insomnia and, loss of weight, loss of pleasure, depressed mood, psychomotor changes, mostly retardation, things like that. And very important part which I have mentioned here is that the mornings are worse. Mornings are worse. Then moving on to peripartum. Why have we not used the term postpartum? We have all heard about postpartum depression, right? We haven't used the term postpartum. We have used the term peripartum because it often starts even before the birth of the child. So it often starts during pregnancy or within the 4 weeks of the delivery. So that is why we call it peripartum. Okay. Symptoms may be severe, and a lot of times it also, takes a little time and lessens by time. Okay, so now moving on to atypical. Now this atypical specifier, we can say this is something opposite of melancholic. Okay, in this the person's mood temporarily lifts. Okay, whenever something positive happens, it temporarily lifts. We have talked about mood reactivity here. We have also said in melancholy that there is no mood reactivity. What do we mean by the term mood reactivity? So whenever something positive happens, the person temporarily feels happy, something positive. Okay, but that is very short-lived. Okay, that is what we call mood reactivity. Okay, and in atypical we also have hypersomnia, increase of appetite, increase of psychomotor functions, and we have also mentioned that lead-in paralysis. This is this heavy feeling in the legs. Okay, this is what atypical is. So it is somewhat opposite of melancholic. Then we have seasonal. Seasonal is basically something that happens in a particular season. Okay, it is usually winter season, and whenever the season changes, normally the symptoms disappear with it. Okay, then moving on to with psychotic features. When we say with psychotic features, basically we are saying whatever we discussed, delusions, hallucinations, disorganized speech, thought, behavior, things like that are present with depression. Now, an important question that comes here is, how is it different from schizoaffective disorder? You remember schizoaffective disorder, schizophrenia symptoms plus a major mood episode. How is it different from that? In schizoaffective disorder, the symptoms, the episode, the mood episode should be present independent of the psychotic features. Psychosis should be present independent of the mood episode. Okay, in this, it occurs with it. It is occurring with the depression, with depressive symptoms, with depressive episode. Okay, and then we talk about other specified or unspecified. Basically, we are saying that it does not fit a specific specifier. It does not meet some kind of criteria, because that is how reality works. You can't fit everything in a box, right? One term that we have to discuss here is mood congruent and mood incongruent. What do we mean by the term mood congruent or mood incongruent? Mood congruent basically mean that the psychotic features that are happening is congruent to the mood. Okay, like having negative thoughts because you're feeling depressed, you're having negative thoughts like that. But mood incongruent would be these psychotic features are not does not match your mood. Like it could be, I'm feeling depressed, I'm feeling I don't feel pleasure in anything but I'm having hallucinations like some alien invaded on the earth. Okay, something like that. So things like that, it does not match the mood. So that is mood incongruent. So these were the MDD specifiers. Now let's move on to the second one, which is persistent depressive disorder. It is also known as dysthymia. Now, how is this a different disorder in itself? Persistent depressive disorder is more chronic in nature. It persists longer. It is not that intense as an MDD episode, as MDD symptoms, but it is very longer. How longer? So it is mostly more than 2 years for adults and more than 1 year for children or adolescents. Again, for adolescents, it's more of irritable mood, right? In terms of irritable mood. So this is something that I would say, this is my mood, this is how I am, this is how this person is. Okay, that is how you feel, rather than, oh, this person is this person does not come out with me anymore. No, you just feel like, oh, this is just how he has been, this is how he is. Okay, so and a very important part is this symptom that person should not be free of these symptoms for more than 2 months. If they're free of these symptoms for more than 2 months, it is no longer chronic for a longer period of time, for 2 years. So we cannot call it a persistent depressive disorder. Okay. Less severe, it is chronic. Okay. So how do we understand, how is MDD different in PDD? Okay. So as we already said, MDD, first of all, is episodic. MDD is episodic, while PDD is constant. It's persistent, as the name suggests. It's constant. It's like a constant emotional cloud that is always there. Okay, it's like that. So when we talk about MDD, you can recover from it, and you can be symptom free. It's like you hit the rock bottom fast, and you also climb out of it. But PDD is like you're just falling and falling and falling, and never actually hitting the bottom, never hitting this, just falling. So it's not always severe. You don't touch the rock bottom. You're also not climbing out of it. So that is how PDD is. So what happens if, a major depressive disorder and persistent depressive disorder, basically an episodic depressive episode and this constant PDD happens together? What is that then? This is called double depression. This is called double depression. What is double depression? When MDD and PDD happens together. Okay. Now let's discuss the other disorders under depressive disorders. First is DMDD. What is DMDD? Disruptive mood dysregulation disorder. Disruptive mood dysregulation disorder. Okay. So what is this disorder basically? Now, first thing that we need to know about this disorder is that this disorder only occurs in children and adolescents. 6 to 18 years, 6 to 18 years. Now, what happens in this disorder exactly? So there is this persistent irritability in this child, okay, and there is some kinds of temper outbursts that you can see in this child, and which is out of proportion than normally what is required out of the situation. Okay, so why is this a different disorder now? This disorder was basically given to reduce the number of diagnosing, the over diagnosis of bipolar in children, pediatric bipolar. That is why this was made a different disorder in itself. Okay, now how do we differentiate this disorder with ODD and CD? ODD is oppositional defiance disorder and CD is conduct disorder. How is it different from these two? ODD, oppositional defiance disorder, is basically I will not do anything, and especially to authorities. So basically disregard of anything the authority says. Oppositional defiance disorder, I won't do what you're saying. In fact, I'll do the opposite of it. Okay, oppositional defiance disorder. And what is conduct disorder? Conduct disorder is violating someone's rights. Not following social rules. I will break rules and hurt others. That is what conduct disorder is. In disruptive mood dysregulation disorder, there are just temper outbursts. There is irritability. They're always irritated. They're always like shouting and all. But they're not particularly defying anyone or breaking any rules, violating social norms. Nothing like that. Then we have PMDD. What is PMDD? Premenstrual dysphoric disorder. Premenstrual dysphoric disorder. Now, I am pretty sure everyone has heard about PMS, right? Premenstrual syndrome, right? What happens in premenstrual syndrome? There is the heightened mood swings, okay, irritability. You feel like crying sometimes. You feel like laughing sometimes, crying sometimes. Shouting at someone. So this is basically like a severe form of PMS. Okay, when does this happen? In the luteal phase of the menstrual cycle, which is basically just before the menstrual cycle starts, the periods start. Okay, so after ovulation, before the menstruation. Okay, what should be present there? More than the 5 symptoms that we have discussed before, right? So more than 5 symptoms should be present when? The luteal phase, before the menstruation, after the ovulation period. Okay, and it normally improves after the female gets their menstruation. It normally improves after that, and yes, it is important that it does cause some kind of clinically significant distress, functional impairment, distress. So that is what premenstrual dysphoric disorder is, a severe form of PMS. Then when we talk about other specified or unspecified disorder, again the same thing, does not meet the criteria and all. Okay, but obviously not everything meets the criteria. Now, as I said, we'll talk about the mock test. So let's talk about the mock test before we move forward to the bipolar disorder. Okay, so you can attempt the mock test for this session. What you have to do is you have to click on the link that is provided in the description. You enter your name, your registered email ID, and the test code for the series. You have to write the test code for the series. The test code for the series is, noted down properly, AK112. AK112. Now, remember, do not leave any space while entering the email ID or the test code. Attempt the mock test and gauge your understanding of what you have learned out of the session and practice what you are not able to solve. It's okay to not be able to solve some questions, but what is important is practice. Okay, great. Now that we have talked about this, let's finally move on to bipolar disorders. So to understand bipolar disorders, we need to know 3 things. What are those 3 things? Mania, hypomania, and depressive episodes. So we have already discussed depressive episodes. So let's move on to what actually mania is. What are the symptoms of mania? So basically, when we talk about mania is basically abnormally elevated, expansive, or irritable mood. What do we mean by abnormally elevated, expansive, or irritable mood? Extremely high energy, high activity, too much of talking, too much of everything, that to the point that it impairs your judgment, it impairs your working, your relationships, your work, to the point that it could even require hospitalization. That is what mania is. So what are the symptoms according to the DSM? You can remember through the term dig fast. Okay. So what is D? D is distractibility. Distractibility basically means inattention. Inattention to the point that your attention is shifting constantly. Okay, like I'm talking to you, this, that. So that is what distractibility is. This is how you get distracted. Second is indiscretion. Indiscretion basically means engaging in risky behaviors, in impulsive behaviors. There is no good judgment. There is only poor judgment. What kind of risky behaviors are we talking about? Any kind of risky behaviors like, gambling your all the money, or driving very riskily on highways, or inappropriate sexual relationships, sexual behaviors. So basically, any high risk behavior that causes pleasure, any high risk pleasurable activity. Okay, G is grandiosity. When we talk about grandiosity, it is basically an exaggerated, sense of self-importance. Okay, now this could be on a range. It could be just overconfidence. You don't know anything, I know it. Something like that. To the point, it's grandiose delusions. You remember we discussed grandiose delusions and delusional disorder. Then we have flight of ideas. Flight of ideas is the thoughts are very rapid. One on the top of the other. This is so fast that you're not able to comprehend it, catch it. Remember, there are always link between what they're talking. There is no losing of associations like schizophrenia and all. They're all linked, but it's just so fast that you're not able to catch it. Okay, then we have A, activity increase. When we say activity increase, they become extremely productive, extremely goal-oriented. Okay, but the problem here is they start a lot of things, everything that is productive, that is something that they are supposed to achieve. Okay, but they finish very, very few. Then sleep is decreased. When I talk about decreasing sleep, it's not just that they're not sleeping. It's not insomnia particularly. It's more like they're sleeping just for 2 to 3 hours, but that is enough for them to have complete energy. They feel like they are full of energy. They do not need energy, more sleep to feel more energized. Then we have T, talkativeness. Here the term is pressured speech. What do you mean by pressured speech? Pressured speech is basically very excessive, very rapid, very loud talking that is difficult to interpret, difficult to interrupt as well. You're not able to even get a word in. That is how fast they'll speak. It sounds so pressured. Now, how long should these symptoms be at least? Okay, so the duration is more than 7 days. More than 7 days. At least it should exist for 7 days or more than that. How many symptoms should be present? So we are saying that there should be more than 3 symptoms. But an important thing to remember here is when we are talking about more than 3 symptoms, it is only when there is elevated, expansive mood, there is some kind of impairment, there is hospitalization, then more than 3 symptoms are enough. But if the mood is only irritable, we need at least more than 4 symptoms. When do we need more than symptoms? When the mood is only irritable. Okay. So if a person is talking very fast, sleeping very little, spends freely, and feels unstoppable, requires hospitalization, 3 symptoms would be enough. Okay. Now let's talk. We talked about mania. We know what mania is. So what is hypomania then, and how is it different from mania? So it is different from mania in 2 terms basically. It is intensity and impact on daily functioning. Okay, so what we're trying to say here is how much it disrupts a person's life. Basically, we're asking this question: how much is it disrupting a person's life? Okay, and that is how you differentiate between mania and hypomania. So, how much it is disrupting the person's life for at least 4 consecutive days. 4 consecutive days. Okay, then it is hypomania. So basically, the symptoms are same, but it's just less severe for less days, and it affects the person. Does not impair the person to that extent. Okay, we can understand this by an example. So there are 2 people, A and B. Let's discuss A first. Okay, this A person sleeps only for 3 hours. Okay, has started 5 businesses. 5 business plans, have spent 5 lakhs rupees on it, okay, and believes that, he is on a special mission from God, to the point that this person had to be admitted to the hospital. What do you think this is, mania or hypomania? Whenever, first of all, there's a case of hospitalization, it is always mania, it is never hypomania. Okay, how would you understand that? We can understand by understanding this, the second example. Okay, so again, this B person is sleeping for 5 hours. Okay, now, and this person has been sleeping for 5 hours, and every 4 to 5 days, this person studies online, like pulling all-nighters every 4 to 5 days. Okay, but they finish all their assignments in that night. Okay, and they keep on talking, but at the same time, they always come to class, they always perform all the functions normally, they complete all the assignments, attend all the classes. Okay, they're always talking all the time, and just pulls all-nighters, and it doesn't affect them, and not having enough sleep. So what would you call this person? You just call this person that, okay, maybe he's too much committed or something, or sometimes this is missed to the point that, oh, this person is just having a good day, or just having a pressured day, or something like that, right? But it is so different. Here you won't be able to recognize, because this person is functioning normally. Their life is not impaired. Okay, they're still sleeping, but just not enough. Okay, but on the other hand, that person, they have recklessly spent, they have to be hospitalized, they're just not sleeping, or sleeping the bare minimum, they are having delusions, they're having grandiosity to the point that they're delusions. So this is how we can differentiate between mania and hypomania with these 2 examples. Hypomania is sometimes missed to the point that, oh, this person is just having a really good day, or this person just has maybe a very happy mood. Okay, something like that. Okay. So now that we have understood mania, hypomania, and depressive, let's understand bipolar 1 versus bipolar 2. Bipolar, again, opposite 2 ends, that's why it's bipolar, depression and mania or hypomania, 2 ends. Okay, so in bipolar 1 disorder, what we are saying is that for the diagnosis of bipolar 1, there should be at least 1 manic episode. 1 manic episode, and it's a bipolar 1. That is all it requires. It does not, but there could be a depressive episode. Okay, or it could not be. You do not require a depressive episode for bipolar 1. What you require is only 1 manic episode. Okay, bipolar 2. Now, what you require for bipolar 2 is you require one hypomanic episode and at least one major depressive episode. One hypomanic episode, so it should fulfill the criteria of hypomanic at least once, and at least once the criteria of MDD, major depressive episode. Okay, and they should never ever have a history of even one manic episode. These are the three criteria for it to be a bipolar. The moment there is even one episode of manic, there's even one manic episode, it is a bipolar 1 disorder. Okay, so what is a mixed feature? For mixed feature, we are saying basically that depressive and manic or hypomanic occur together. Okay, so it's like, I feel hopeless, but also I cannot sleep. And I keep on talking. So, I feel useless, but, my mind just won't stop racing and I haven't slept for 3 days. So, at least 3 symptoms of opposite mood pole should be present. So, when I'm saying that opposite mood pole should be present, so it could be depressive episode with 3 manic symptoms or manic episode with 3 depressive symptoms. So, if it's a depressive episode, it should have at least 3 manic symptoms. These are 2 specifiers. If it is a depressive episode in mixed features, this should at least have 3 manic symptoms for it to be a mixed feature one. And if it is a manic episode, it should at least have 3 depressive symptoms. Okay, so that is how you decide if it is a mixed feature. Then we have cyclothymia. Cyclothymia is basically, so you know how PDD is for MDD, right? It's basically a more chronic, a longer version of MDD. That is how cyclothymia is basically for bipolar. It's a milder version, it's a chronic version of bipolar, where it should be at least for more than 2 years for adults and at least 1 year for children. Okay, it never fully meets the criteria of either hypomania, mania or depression. None. If it met the criteria of depression and none of the other, it would turn into MDD. Okay, if it meets the criteria of manic, it would turn into bipolar, right? Bipolar 1. So it should never fulfill the criteria of mania, hypomania or MDD. Okay. Now, let's understand the etiology of mood disorder. Basically, we are saying again, it stems from when biological factors, social factors and psychological factors come together. That is how mood disorders arise. Let's discuss some of the biological factors first. First, we're talking about genetic vulnerability. Again, if you remember, we discussed stress, that diathesis stress model. When your relatives, your parents, your twin have this kind of genetics, you're more vulnerable to these disorders. Then there is stress diathesis model. The same thing, if there is some kind of vulnerability before and then the environmental stress, can activate it and cause this disorder. Then we talk about HPA axis dysregulation. What is HPA? HPA is hypothalamic pituitary adrenal axis. Hypothalamic pituitary adrenal axis. Dysregulation happens. This is a stress response. So what happens is basically when there is persistent high cortisol level, it could be one of the reason for mood disorder. Why persistently high cortisol? Because cortisol is a stress hormone. That is why. Okay. Then we are talking about circadian rhythm disturbance. Basically, what we are saying is that sleep and mood are closely related to each other. So whenever one changes, it affects the other. So your circadian rhythm, which is your biological clock, okay, when that is disturbed, okay, your mood also get disrupted. Okay, moving on to neurotransmitter imbalances. So we're talking about serotonin. Serotonin basically is linked with feeling, low levels of it is with feelings of depression, suicidal ideations. Norepinephrine is more related to feelings like, I can't focus, I can't concentrate, I can't think properly. Then we have dopamine. Dopamine is, known for reward and motivation, motivation, pleasure. So it is the reason behind anhedonia, loss of pleasure, loss of interest. GABA and glutamate. GABA and glutamate are basically, GABA is inhibitory, glutamate is excitatory. So these are excitatory and inhibitory neurotransmitters, and any kind of imbalance also disrupts your mood. Then we have neuroimaging findings. So when you're talking about prefrontal cortex, it basically is related to reduced activity in this. Reduced activity in prefrontal cortex. One of the features is poor concentration, not able to think properly, perform properly. So, prefrontal cortex is related to planning, concentration, things like that. Hippocampus is one of the major regions for recurrent depression. Recurrent depression. Then we have amygdala. Amygdala is related to, emotions, fears. So there is hyperactivity in that. Okay. So now we discuss some of the biological features. Let's see some of the psychological theories that can explain why is depression developing. Let's start with Beck cognitive theory. Now, to understand Beck cognitive theory, I'll start with an example of two students. There are two students. They gave the same exam. They both failed. Okay, now, the first student thinks, okay, fine, I did not prepare well for this exam. It's my fault. But, next time I'll work harder. So, this person is disappointed, but this person moves on. There's the second student. They say, I failed this exam. I'm useless. I will never be able to succeed in life. I won't be able to achieve anything. So it's not just the event that is causing this. It is also the negative thinking. Now, where does this negative automatic thinking come from? It comes from deeper schemas, deeper thoughts that are embedded inside you. And what is that deeper thought? That I'm not good enough. I'm not good enough. It comes from Beck's cognitive triad. Okay, Beck's cognitive triad is basically self, world, and future. Negative thoughts about self leads to negative thoughts about the world, leads to negative thoughts about the future. It's like a triad. Okay, so it's basically saying that if I didn't succeed in this, I won't succeed in life. I will never succeed. Now, what happens with this thought? Okay, now this thought leads to low mood all the time and then depressive symptoms. The second theory is Martin Seligman's learned helplessness theory. Now, you remember the first child who said that, it's okay, I did not prepare well, I'll prepare again, I'll give the exam again. Very positive thinking. This person prepared, failed again, prepared, failed again prepared, failed again. This person has tried at least 4 to 5 times and always ends up failing. Now, what will happen is, this person will ultimately start believing that no matter how hard I try, how hard I study, I never, succeed. So, they will develop this thing that no matter how much effort I put in, I'm never gonna. Now what happens is, maybe there was some kind of problems happening due to which they were not able to clear these exams. Now, a good opportunity comes in front of them. Okay, a really good opportunity. But they will not even try for this opportunity because they think that the failure is guaranteed, because they're always failing. So now they've just thought that I won't even try because I'm anyways gonna fail. So repeated failure caused helplessness, hopelessness, I'm never going to succeed, and hence depression. Now, what is behavioral activation then? Now imagine this person, this person obviously had friends, so he used to go to walk with friends, movies with friends, loved to play badminton, Now this person stopped doing all of these things because he just doesn't feel like doing it anymore. They're just in their bed all the day, they do not do anything. And now this has become a very vicious cycle. So the more they enjoy less, right? The more they're enjoying less, the more depressed they become, right? So now what behavioral activation does is breaking the cycle. Breaking the cycle is basically what behavioral activation is. What we'll do is, we'll tell to do this person's small activities. Like, even without motivation, you don't feel motivated to do this, still do it. Do it for 2 minutes, 5 minutes, 10 minutes. You know what? Just go for walk for 5 minutes. Just call up your one friend, talk to them for a minute, even if you do not feel like doing it. Now, what happens is, when that, you walk for that 10 minutes, you call a friend for that 1 minute. Even without the pleasure, you increase these small behaviors that used to give you pleasure. Now, what will happen is, these will eventually release some kind of positive emotion, some kind of positive expression, and that would actually lead to gradual improvement, gradual recovery, improved mood. So this is one of the techniques even used, called behavioral activation. So these are 3 different theories, talks about how depression develops, how we can break the cycle and things like that. Now, do you remember the patient Sunita, the 42-year-old school teacher? Let's say that person is still our patient. So, patient is Sunita. Now, we already checked the DSM criteria, right? But there is an actual way to check DSM criteria, which is one of the ways, obviously not the only way, is called SKID. We covered, we briefly mentioned this in module 1. SKID. What is SKID? SKID is the structured clinical interview for DSM-5. It basically is a very semi-structured interview for, checking for DSM-5 criteria. So, using this interview method, we checked, using the clinical interview method, we checked for the DSM criteria. Now comes, measuring how severe the symptoms are, what is the progress level and things like that. For that, we use rating scales. What you are using for that? Rating scales, assessment scales and things like that. And then, as I already mentioned, suicide risk assessment is very, very important when it comes to depressive episode, mood episode cases. So we do a suicide risk assessment, which includes suicidal thoughts, suicidal intent, suicidal plans, suicidal attempt, and not only that, but what protective factors are present in this person's life. Even we check that. And based on all of this, we finally make a diagnosis. So what are these rating scales that we are talking about? So let's start with first PHQ 9, Patient Health Questionnaire 9. Now, what you need to remember is it's a self-report. It's a self-report. Self-report is something that the patient fills themselves, okay, based on what they feel. Now, this PHQ-9 is based on DSM criteria, okay, so it includes all the DSM criteria and all. Then, let's discuss Beck Depression Inventory 2, BDI 2. Again, why? Because it is also a self-report, and what it focuses on is understanding the severity level of depression, okay. So, it is, a 4-point scale on which it understands it. It has 21 items. Remember that. Okay. Then is HAM-D. HAM-D is Hamilton Depression Rating Scale. Now, this is a clinician rated scale. Basically, the psychologist, the psychiatrist, the clinician uses this scale to assess the severity level of the depressive symptoms. Okay. It is also gold standard in research. Okay. And then we have YMRS, Young Mania Rating Scale. This is again a clinician rated scale. This is also a clinician rated scale, okay, for manic symptoms. It also measures the severity level of manic symptoms. Okay, then we also have some more MDQ for bipolar. It's a self-report. And then we also have MADRS, Montgomery Asberg Depressive Rating Scale. It is also clinician rated scale. Okay, so these are some of the major ones that you have to remember. Then the treatment. We won't go into a lot of detail. You can read it yourself. We have medication, psychotherapy, ECT, and lifestyle modification, psychoeducation. Again, lifestyle modification, psychoeducation, you understand that. We won't go into detail for that one. Medication, there are antidepressants, which is the first line treatment mostly for depressive symptoms. SSRIs are selective serotonin reuptake inhibitors. SNRIs are serotonin norepinephrine reuptake inhibitors. TSS are tricyclic antidepressants. MAOIs are monoamine oxidase inhibitors. So these are some of the antidepressants. Then we have mood stabilizers for manic symptoms. For manic symptoms, lithium is the gold standard. Okay. Then we also have some atypical antipsychotics and all. One thing that you need to know is that you never give antidepressant monotherapy for bipolar disorder. You never give antidepressant monotherapy for bipolar disorder because it can increase manic symptoms. Now, then if we talk about psychotherapy, CBT is the most common one that is used. Then we also have IPT, and we already mentioned psychoeducation, supportive therapy to provide emotional support and all. ECT is mostly used when, depressive is resistant to treatment. This is like a last measure kind of thing, okay, because it is very, very risky. Then we already mentioned lifestyle modification and psychoeducation. So these are some of the treatment for mood disorders. Look into it briefly. It could be helpful. And remember that it's not one thing that is used. It's like a mix of all of the things. Not one particular treatment can be the best for everyone. So we decide based on what the symptoms are, what would fit that person the best. Okay. Now we are done with mood disorders. Let's check what you have learned. So you know the way. I say the question, you pause the session, you answer it, you unpause it, you listen to the answer. If you answered it correctly, very good. If you did not answer it correctly, that is also okay. And go to that page again, understand what you missed. Okay? So the question number 1 is, a patient experiences an abnormally elevated mood with increased energy for 8 days, causing marked impairment in social and occupational functioning. Which diagnosis is most likely? A. Hypomanic episode. B. Major depressive disorder. C. Manic episode. D. Cyclothymic disorder. The answer would be C. Manic episode. Why? Abnormally elevated mood, increased energy for 8 days. This is more than 7 days. Causing marked impairment in social and occupational functioning. This is not hypomanic ever. Okay? This is also more than 7 days. Right? That is why it is manic episode. Okay. Remember, if there is hospitalization or extreme impairment, it would be manic. Question number 2. A woman develops depressive symptoms during pregnancy and continues to experience them after childbirth. Which MDD specifier is most appropriate? A. Seasonal pattern. B. Melancholic features. C. Peripartum onset. D. Atypical features. Very easy question. Pregnancy, right? It already said MDD specifier. So it would be peripartum onset. Okay. Question number 3. According to Beck's cognitive theory, which of the following is not a component of the cognitive triad? A. Negative view of self. B. Negative view of the future. C. Negative view of the world. D. Learned helplessness. The answer would be D. Learned helplessness. Remember, this was one of the theories given by Martin Seligman. And this cognitive theory, we already said, it is a negative view of the self, world, and future. Okay. Question number 4. A patient has experienced a persistently depressed mood for more than 2 years with no symptom-free period longer than 2 months. Which diagnosis is most appropriate? A. MDD, B. PDD, C. Bipolar 2, D. Cyclothymic. The answer is B. Persistent depressive disorder. We already said more than 2 years. It is not symptom-free for more than 2 months. Persistently depressed. So it should be PDD or dysthymia. Both are the same things. Not MDD. Okay. Last question. Which of the following rating scales is specifically designed to assess the severity of the manic symptoms? A. HAM-D, B. PHQ-9, C. BDI-2, and D. YMRS. The answer would be D. YMRS. This is Young Mania rating scale. BDI is Beck's Depression Inventory 2, PH2 is Patient Health Questionnaire 9, and HAM-D is Hamilton's Depression Inventory. Okay. So, with this, we are done with mood disorders. In the next session, we will be talking about anxiety disorders, OCD, PTSD, and other disorders. So, till then, study hard, attempt the mock test, and we'll see you soon. Bye-bye. Take care.